walking, ataxia, I'm not stumbling over. So I have coordination, so where's mine? Where's cerebellum? All right, fluids, know your electrolytes, medical emergencies, we still do the ABCs, those don't change. Infections, these are not new to you. So same thing, if there's an infection going on in the brain, it's still gonna have vasodilation, permeability, redness, swelling. That stuff is still going on within the brain. We talk about the nervous system. This is just a nice to know. Here's our myelin sheath. So see how nice and shiny these are? The picture doesn't do justice. But
The orange
these
part is
are
shinier.
nice and plump and juicy, and they're the ones that send signals to the other neurons to make muscle movement. Serotonin, or I'm sorry, we don't need to talk about that. Acetylcholine and dopamine are lobes of the brain. These are all on blackboard, so you guys can print them off. So here's the skull. We have meninges that I think Ashley brought up the meninges. That covers and protects the brain tissue and the spinal cord. Because when we're talking about like hematomas, subdural hematomas, epidural hematomas, some of them, they're outside the brain tissue, putting pressure on the brain, or the inside the brain. Here's our two vessels, blood-brain barrier, we talked about this. Spinal cord, we'll just go through. So this is on blackboard too. Take a picture of it, you'll need to know this. Here's another way I've seen on the internet of how to remember your cranial nerves, get to know your cranial nerves, assessment, diagnosis, we'll talk about those with each one. All right, let's do some practice questions. We're just assessing. The nurse intervenes when the nursing student assesses which of the following: speech formation in the frontal lobe, writing out math equations for the parietal lobe, using the tuning fork for the occipital lobe, counting a patient receipt of phrase stated for the temporal lobe.
See?
C, why?
Because that's for listening.
What lobe is that?
The temporal.
Temporal lobe. So yeah, so make sure I know it's easy now, but you guys
You're
all
making
have
harder.
seen what our test questions are like. So just read, trust your gut, you know what you know. So yes, this is correct. C is the
So they're making it harder than this.
because we're stopping the nursing student, right? We're intervening, the nurse intervenes. So we're looking for the wrong answer. The nurse anticipates which education statement for a patient who has received a diagnosis of Parkinson's. I know we haven't talked about Parkinson's, we kind of did a little bit with a certain something. So low supply of serotonin is related to depression. Remove scattered drugs to decrease the risk of falls.
B.
The lack of dopamine produces tremors and immobility.
Yep.
Or areas of the spinal cord control movement. Are they all right? Correct?
So
You're all
safety
right. But
Safety
go back
first,
to
B.
the question, because the question is directly associated
Or
with
patient.
Parkinson's disease. Because a low supply of serotonin is related to depression. That's true, but we're not talking about depression. Throw that out. Remove scattered drugs and
Yeah.
decrease the risk of falls. Is that true?
Yeah.
Yeah.
Yeah, you need to educate them on that.
But we're looking at the diagnosis. So throw out B, because that could be someone that's coming home with a hip fracture.
D.
That could be our little old lady
Letter D.
that has dementia that's now going home
Letter C.
because her kids don't want to go to nursing home.
Oh,
The lack of dopamine produces tremors and immobility.
that is
which
directly related
the
to
diagnosis for Parkinson's. And then areas of the spinal cord control movement. That's correct too, but it doesn't have anything to do with the question. So if you're going through your test and you're like, yep, that's right, make sure you read all of them, because most of them, technically, all of right, but there's always one more right than the other.
The
and
nurse
that's why we want
anticipates
you to
that
go
which
back and read
education
the
statement for a
questions,
patient
right?
who is recently diagnosed with Parkinson's
Quite
disease.
cool. So that
A.
should help you
Like serotonin is
kind
related to
of
depression. B.
focus in on
Scattered
the
thoughts
right
to decrease
answer.
the risk for falls. C. The lack of complete.
Okay, which technique does the nurse use to
see the
assess damage of cranial nerve 8? And our cranial nerves are in room of numerals, it's not number 8. So which patient presents with symptoms of unsteadiness? But we're only talking about unsteadiness, right?
No, cranial nerve 8 is equilibrium.
You guys are right.
When a patient presents with symptoms of
We're looking at cranial nerve 8.
That's a good question. I don't know, I must have Googled that. But okay, ask the patient to read the exit sign. We know that's the occipital lobe or cranial nerve, the optic nerve. Have the patient identify an orange with their eyes closed. That's true, but that's cranial nerve 1. Using the tuning fork for a hearing
C.
test, and you're like, well, I'm not assessing hearing, I'm assessing unsteadiness. Having the patient stick out their tongue, so that's cranial nerve 12, but the tuning fork is cranial nerve, or the unsteadiness is also with cranial nerve 8,
hearing about.
because our balance, remember we have those little crystals in our ears
Wait, this is getting way too hard.
I'm trying to,
that help with balance.
cause she confused me. I thought it wasn't C at first, but it is hearing and balance.
Okay, you guys get that one? And it's C, unfortunately.
She said unfortunately.
Here's the Glasgow Coma Scale. I don't think I'm gonna spend too much time on it because we went through it pretty well. There are 2 positions I do want you guys to remember. It's the decorticated and debriated position. And I always think
Bottom one is
decorticated,
the worst.
your arms come to the spinal cord, come inward, so it's by your spinal cord. So you're, it's decorticated. Debriated is when your arms are flat out and you're, it's just all bad. No
But see
matter where it
core
is.
in that, so
Sometimes
he's
they're
coming into the
flexing.
core, and then there's a bunch of E's in decelerated, he extends, and
Debriated.
he's extended.
That both of them just show that there's some kind of spinal, not spinal cord, brain stem damage.
Subscription, 2 years.
Which one?
This is bad when you
The
see this.
simple nursing.
It's just brain
Used
Yeah.
it.
So, sometimes, especially in the
They have-
debriated, have you, like, you run into it a lot? Not a lot, but.
Not a lot, but usually this means, like, when we see this, or not.
Yeah, debriated is when their arms are stretched out, their wrists are kind of out like that, and sometimes they're pulsing. Why, I don't know. Their fever, have you experienced where their fever is like way high? Yeah, their fever is way high, but yeah, they're not probably gonna live. This means that there's, brainstem damage.
And the other one is, you said.
Decorticated, that means their arms are to their cord, their spinal cord.
Oh. Is
To
that when
help you
they're like,
remember.
is that like a contraction, when they're contraction?
No, it just is
They're
brain.
dead, they're dying, they're dead.
They do this, but I'm just telling you guys to remember the 2 positions. I had somebody, they like to decorate, so he's like, I would always think about it, he goes, I get to decorate, so.
Oh, like the elf.
So
The elf, he's all excited.
That's what he said.
Your cord.
And that's better than the
Alright,
other one.
nursing
little
interventions,
bit.
I was gonna delete this, but that's okay. So we
They're
talked
both
about
bad,
TIA
but-
and stroke. So here's a mini stroke, warning stroke, brief interruptions of cerebral blood flow due to a clot, vasospasms, or, arterial hypertension. It's temporary, so a few minutes to 24 hours. They could have the same symptoms as a stroke, blindness in one eye, double vision, unsteady gait, ataxia, and I think I put ataxia.
Hypertension.
Hypertension,
Smoking.
smoking,
Alcohol.
high
Obesity.
cholesterol, AFib,
Obesity.
diabetes, uncontrolled or controlled.
Uncontrolled. Look at me.
Uncontrolled diabetes.
I'm happy junior.
Did we miss anything? Sedentary lifestyle, diet. Aneurysm, hemorrhage. Age, so those are
Is this just for strokes?
age, family history, gender, those are non-modifiable. Diagnostics, we're doing carotid ultrasound, CT, angiography, and we're looking at that EKG, which we talked about. Focus care, did I miss any of these? Antiplatelets, control diabetes, and we've talked about all this. So your cholesterol comes back in play again. Oh, this is where we got. So the carotid endarterectomy is where they go in and they can clean up the carotids, remove any plaque, any clots, so we get good blood flow to the brain. So, okay, how does the nurse interpret a patient with a Glasgow coma scale of 3?
Intubate.
The patient is stable, the patient is totally unresponsive, the patient had a stroke.
He's bad. He's bad, isn't he?
I didn't take C for this one. So which one is it? D. Where? D. 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 A 68-year-old Mr. B is admitted following a TIA who is spontaneously resolved. Blood pressure is that. Which action is the highest priority to implement?
C. D. B. A.
We gotta keep this patient alive, right? We gotta worry about, what are we worried about? If those symptoms have resolved, are we still worried about stroke?
Yes, big time.
Yeah, so we're
C.
still doing neurovascular checks. So we're checking them frequently. So we will still do neurovascular checks. That's our priority because the sooner we check a stroke, that's the best that we can do. Didn't we have someone at clinical? Not you, you're this group. At clinical that had a stroke, but the symptoms started the night before and. That was yesterday, but this was a patient that was already admitted.
Oh, yeah, we did.
Yeah, it was. But, so the sooner you find stroke symptoms, identify it, the better. But yeah, the patient that came in yesterday for
We
the
got a
stroke
lot of
alert,
stroke patients on the team.
their symptoms started last night. Because what is the magical hour that we
3.
have?
They said 4.5 or 3?
3.
4.5?
From when the symptoms began, sorry.
3.
From when the symptoms began before we can have treatment started with TPA.
3 hours.
3?
3.
4.5.
4.5 hours.
Why
So
does
that
everything say
means
3?
If my symptoms started at 8:30 today, or let's go with 8 o'clock, that's easier to. So by 12:30 this afternoon, I can get TPA and I have an ischemic stroke. At 12:30, oh, I got it.
Oh, you got it?
Sorry. Yeah, one of the students figured it out.
Okay,
Or 2 of
wonderful.
the students.
Okay.
Thanks. I forgot it.
We would have been waiting a long time.
Well, it only took them 45 minutes.
We would have been waiting.
I have 4.5 hours to start treatment, and it is like on the dot. It's like if you go a minute over, I don't wanna be the one calling the doctor and go, oh, we didn't start the TPA in time. It's not good. Because this is gonna save this is a life-saving
Matter.
medication. Because they have an ischemic stroke, they have a blood clot in their brain, and we gotta get treatment to
It's very
that
expensive.
brain before it becomes permanent damage.
My dad had symptoms of a stroke. I don't think
so
we
we had
had one,
4.5 hours.
but they
That's
gave him
why
one of
the
those,
patient
and
that
my
I
mom
dropped
was
off
like,
that
"Oh,
only
baby,
said
yeah,
5,
make sure it's
he
not
was
big
literally dropped off
expensive."
at the ED. He could only say 5. We couldn't find out when those symptoms started. We didn't know anything, so we couldn't start it. He would have been a perfect candidate for TPA, but because we didn't know that. Pardon me? No, couldn't do that. I tried that too. Couldn't write anything out, but couldn't talk, couldn't do anything, but because we couldn't figure it out, we couldn't start that TPA. Because it didn't start last
Did he
night,
die,
it
or?
didn't start, when did it start? We don't know. He was texting at noon though.
What's the risk of starting it too late?
So a fibrolytic called TPA, it will go in and dissolve any clot in your body. So what's the risk of that?
Bleeding.
High risk of bleeding out. So that risk of bleeding out trumps the TPA at
Okay.
this point. But that is the doctor's decision. Now, have I seen TPA given after that? I have, but that we let the doctor make that decision. Yes.
I want to take this kind of. Give him blood.
I know. Who wants to have a stroke
Like,
forever?
how are you gonna remember? Like, what if they bring you and you had a stroke? Like, how?
How are you gonna say it has to be someone else telling them for you?
Yeah.
What if it's just your kids and they don't know anything?
Yeah.
Right.
When we give the TPA, they're at a high risk of bleeding out.
So then
So
what's
they can live with those
what do they do if they
deficits.
don't need time?
They grab, I think, but they're gonna have to live with those deficits, instead of increasing the risk for bleeding. Their brain
Stroke
tissue
deficits.
then already.
Give me.
really-
Give me the
The brain
stuff.
tissue is pretty much already dead, so why would we increase the risk of bleeding out and then damage is already done?
I mean, what makes
I had a friend
bleeding
who, well, not a friend, a friend of the family, that he's my age, and this goes back probably 5 years ago. He was at home, he was with his wife literally just left him, she's a nurse, and she's like, okay, I'll meet you on the road, you go pick up so-and-so at school, and then I'll meet you wherever. Well, the son started calling, was like, where's dad, where's dad? This is only like 15 minutes later, where's dad, where's dad? So she's like calling him, dad's not answering the phone, so she called my brother-in-law, and she's like, will you go over there? Sure enough, he had a stroke. And they started TPA because it was within the 4.5-hour window, but because of the bleeding, his carotid artery ruptured. So then
Oh,
they
no.
paralyzed him, because now he's bleeding, and I was, oh my God, this is really bad. But he's alive, he does have deficits, but he's alive. But he has trouble walking, and memory is not the best. But yeah, very weak, you can see he uses a cane, but he
So
might.
what caused his stroke?
Blood clot, he had blood clot. Does he have no deficits or stroke? Good question. I don't know. Probably from the stroke, I would assume. But yeah, he he's alive, so they were able to, got him treatment right away. But that's why it's so important for us to educate the community about when those stroke symptoms happen, get them into the emergency room, call EMT, call 911, get them in there right away. Because it can be treated, it just, go ahead.
Do you have to do the non-contrast CT before you start the TPA because of the risk of the hemorrhage already?
Yeah. Because if you go in and you start TPA and they have a head bleed.
Yeah. You're making it work. Okay.
Graveyard, yeah.
So if they come in and it's been 4 hours, you have a half an hour to get
You
your
have a half an
CT
hour.
and get that started.
Protocol
They'll do
is,
it right
as
away.
soon as the patient hits the ED doors, we have an hour to start TPA, but that is anytime. That could be, they've had symptoms for a half an hour, so we have an hour. That's just protocol and our certification for being able to start TPA at our hospital. But if they come in at 4 hours, yeah, we only have half an hour. It's crazy.
How quickly can they do that CT?
Pardon me?
How quickly can they do that
Usually
CT?
what happens is EMT will bring them in, and I'm sorry, I keep pointing at you. But they bring them in, and the doctor and the nurse are during their neuro assessment walking to the hall to the ED. So they don't usually go to a room, they go straight to the CAT scan.
Okay.
The only incident was Monday night, I told you guys about it, but Monday night we had a stroke alert, he came in, it got canceled because the guy started seizing, he started having status epilepticus. So that was delayed, but it turned out it was just because of seizures. But yeah, that's how important it is to identify that cause, check the bleeding, check the CAT scan first before we do any treatment. Yes.
This might come out.
Yeah.
I'm just curious, obviously, like, it costs per hour to pay for TPA, like, they're worrying somewhere that if they get TPA or like they didn't treatment before, I know like people can recover from deficits, like,
Oh, yeah.
certain things can get better or completely go away, I mean, you could recover fully.
Right. It
If
just,
they don't get the TPA and like nothing like treats that, is there a way for them to recover? Does that make sense? 'Cause
yeah,
obviously
the
it's more-
neuro, the brain, it will do what it wants. You'll get a lot of questions like, well, if their symptoms are gonna recover, when will that happen? And it's like, the brain will do what, I mean, you don't know if it will if it recovers, if it doesn't, and usually it takes up to a year. So, a lot of people will ask you, well, okay, they had a stroke, when will their symptoms recover? It's like, well, they will. I mean, we don't know.
Correct me if I'm wrong, but I just wanna know because I've heard people say this, but I don't know if it's true, like, when you like recover from deficits, like that brain part is like dead, like, it's not going to like
Right.
come back to life, your other parts of your brain are making up for it.
Yeah, remember you have collateral circulation in the heart where the heart makes up a new pathway for blood. I don't remember all that. So the brain does the same thing. Or if it's past that 4.5 hour window, there are other treatments for the patient. Do they go in and have a bypass in the brain? They can go in with a cardiac or catheter and they can put TPA just at that spot in the brain, but where they see the clot, but that's a high risk too. So all of these are high risk procedures that, is it worth death or living with your symptoms right now? But that's where the patient and the doctor figure out. I don't think that much money. That kind of money. All right. Did we get past this? I'm way ahead of myself. But these are all good questions. All right. The nurse,
Ask.
I think we're past this.
No, it's not.
I need to, face drooping, so teach about, I'm just gonna go through these. So here's our stroke, there's two different types of strokes, ischemic and hemorrhagic. So we've talked a lot about ischemic, and the problem with strokes is our blood cannot store oxygen or glucose, so we need that continuous supply of blood to keep our brain working properly. It also removes waste products. And really the type of stroke, kind of like what I was saying with the Broca area or the cerebellum, wherever the stroke is, they'll mimic those symptoms. So that's why I say it's important to know the lobes of the brain, because you might be going through something, assessing a patient, they can do, like, maybe their judgment is really good, but they can't hear, but then we're like, oh, okay, so it's probably the temporal lobe. So you can kind of guess where the stroke is. So when it comes to ischemic, hemorrhagic, we got that. Larger, do I need to know about that? We talked about cardiogenic, it could be caused by AFib. There are two differences between like a ischemic stroke from do the symptoms gradually appear? When the symptoms are gradually appear, it's usually from plaque. If it happens automatically, like you're fine one day and then all of a sudden you have symptoms, it's probably a blood clot.
Do we need to know the difference from voted or unknown?
I would know which one gradually appears and which one doesn't. So I guess, yeah. Embolotic would be a sudden onset of symptoms.
So that's why this one usually occurs during COVID, so there's no occurs during symptoms.
Yeah, so that would, so with the arthritic or plaque, you're looking at gradual symptoms.
Oh, something keeps ringing.
Yeah. My phone's here somewhere. There is, kind of like what we were talking about, there's a penumbra region. So as you can see here, this is the dead issue. Here is the clot right here, this little wormy thing. So this dead area is dead, but then the area around it could be affected also. And that's called the penumbra region. COVID, abnormal clotting issues, that's why people are at risk for clots or strokes with COVID because of that clotting issue. Here's the acronym that you need to know and we want everyone in the community to know. B fast, B for balance, E for eyes, can they see, do they see double vision, can they read my ID band, can they read the clock? F for facial droop, is one side of their face droopy or the other side? Arms are arms weak, legs weak. Speech, is their speech slurred? Are they confused? And then time loss, which is brain loss. This is a funny story. So my sister picked up my mom at the airport one time, and it was like a Friday night. I ignored the call because I was like, I'm out, I don't wanna pick up the call. She called back, I said, okay, something's wrong. So she picked up my mom from the airport, she's like, I think my mom's having a stroke. I'm like, okay, great. So I'm like, okay, raise your arms, and I'm doing this on the phone, I'm like, did she raise her arms? Yes. I can hear my mom speaking, so I know her speech is clear. Aaron's like, she came off the plane, she was walking fine, so I'm like, well, that happened, but I thought about it. And then, I go, smile, puff out your cheeks, do all that, raise your eyebrows, and then I hear, I can't. And I'm like, what? She goes, I can't raise my eyebrows, and I'm like, you have Botox, and she's like, yeah. But my sister said her eyebrows were up to her. And then I was home recently, I'm like, Mom, you look like that, it's so bad. Make sure because, what's it called? Oh my God. That mimic stroke symptom, Bell's palsy, thank you. So Bell's palsy, you might have somebody come in with stroke-like symptoms, but it turns out to be Bell's palsy, but that's stroke in their cerebellum, inability to walk, problems with coordination, dizziness, headaches, nausea, vomiting. So that's why when we went through the normals at the beginning of class, what's normal? This will help you with knowing where the stroke is. Heart, brainstem. So the thing with ipsilateral and contralateral, ipsilateral means same side. Contralateral, think about it, contra, other side, opposite side. So our pons is where the cranial nerve crosses. Like we'll have cranial nerves and then they cross sides, so that's why we have contralateral symptoms with a stroke. So if we have a right-sided stroke, meaning their right brain, we're gonna have left-sided symptoms because our cranial nerves cross. So that's the meaning of this ipsilateral and contralateral.
In brains of stroke is the like
Yep, they're all like brain. But brainstem is the worst, yeah. So this is what that means. So if you're having a left-sided stroke, left hemispheric stroke, you're gonna have right-sided deficits. And same thing with opposite of the other thing. So left CBA, I always think is your left side is the smart side. They can do math, they can write, they can that are the smart side.
Left is language and logic. Left is, wait. You said left is the smart side?
Yeah, left is the smart side because they can do math problems.
Left is language and logic, right is calculus.
Right side, I'm not good at the right side period because I'm not artsy at all. I was talking to a student yesterday who, if you've been in my office, there's a sketching that she gave me, so I put it in her brain. And some students have asked me if I drew that, and I'm like, oh, hell no, I can only do like stick figures. So I was talking to her about it. But right side is our artsy, so I'm standing here at the room and I'm looking at that monitor and I'm thinking it's like right in front of me. I'm thinking I can reach out and touch it. So my spatial recognition is off. What else? Visual deficit field. So I might be walking, but maybe I only see the left side. So I'm like walking into doors and whatever. I'm tripping over things on the right side because I don't see them. So their spatial recognition is way off. Motor changes. So we have weaknesses and paralysis, gait problems, cranial nerve problems. We've already talked about that. Motor changes. Communication changes. We talked aphasic. We talked about the Broca area and Wernicke area. What is that down there? Appropriate or perceptual changes. So homonymous humaniosia. I have to look at it to pronounce it. So this is where, like I said, you only see the half of the visual field. So this is damage in the occipital lobe. So sometimes you'll put like somebody, and you want to always put everything in their field of vision. So if you're giving them a tray, you want to put all their food utensils in their, say they can see out of the left side. You want to put it on the left side so they don't have to, they're not confused. You want to give their medications on the left side of the tray so they can see them and take them. And we'll talk about those things after that, because I don't want to get into that. Or sensory changes, unilateral inattention syndrome. This is also when maybe I can only see the left side. I'm not aware of my right side, so I might only put my hair on the left side. I only might put makeup on my left side of the face. I might only dress my left side. I'm not aware of my right side. So it's really important to help people do everything on their right side, their deficit side, before they do the other
So
side.
do they know that they don't know about their other side or no?
Probably not. Eye drooping, involuntary movements of the eyes, proprioception, we talked about that, agnosia, loss of ability to recognize an object. So I might be looking at this and going, I don't know what this is, what am I supposed to do with it? So I had a patient one time, this was when we were in the old ED and we were crowded, and I had a patient that came into the ED and we had to put her in the hallway, and all she was doing was crying, and her only complaint was she couldn't figure out how to make her coffee maker. And the ENT said she's not having a stroke. I'm not blaming it on the ENTs. But I was kind of a new nurse, and I'm like, okay, they said she's not having a stroke. She didn't have a stroke. Well, she had a massive stroke. But it was past the time, so that's what makes me feel better about it. Because she woke up in the morning, and let's get back to that, we might get back to that. She woke up in the morning and didn't know how to make her coffee maker, or she didn't know how to make her coffee. So that's why, so she had the stroke sometime in the middle of the night. This was an afternoon.
So this would have been, I think, rise on.
I don't know. No, she just, I don't think so, because she went to bed normal supposedly, but she woke up and had these deficits. So when did the stroke occur? Somewhere, it could have happened the minute she went to bed, it could have happened the minute she woke up, but we don't know. So that last known normal goes to the night before, because we don't know when that last